Okay, medical assistants, this is your review for your Chapter 2 exam. I didn't put a lot of information on here because I'm going to be honest, most of this stuff you guys should already know because it's actually practicing the venipuncture process. But it does go through a lot of rules and regulations and how to handle situations. So you're going to have a lot of scenarios on this test. So you're going to have to read them very carefully. There are 100 questions, which is a lot. I tried to eliminate some of them. Some of them I deleted and rewrote because I reviewed it, but it will take you a while. You do have 120 minutes to take this exam. So I just put together a little bit of a PowerPoint here to kind of just remind you of some things that you might kind of see on the test that you're going to want to study and look in your book. I did not put the information on the PowerPoint. This is for you to go back to your information and study from. So here on this slide, just a reminder of the equipment that you're going to need when you're performing a venipuncture, your angles, which actually this should be probably 30, less than 30, 15 to 30 degree angle, really when you're doing the antecubital area with the ETS, the system, the evacuated tube system, and then your butterfly, obviously your angle is going to drop down quite a bit more. So just reminder of equipment, take a look at that, make sure you know what it does, what we require, things like that. Location of blood draws, some things to remember when you're trying to determine where to perform your blood draw. And I want you to keep this in mind. First of all, the antecubital, and if you can see, is the elbow area. And these three veins here are in the antecubital. Your first choice would be your median cubital. Your second choice would be your cephalic. And of course, your third choice would be your basilic. And the reason it's our third choice is because of the brachial artery is located underneath of it. So you want to be aware that it's there, just so you know if you hit it, you have to be aware. A few other things to think about when you're drawing blood, different scenarios. One, location of IV sites. You never want to draw above an IV site. If you do draw above an IV site, it has to be shut off for 2 minutes prior to the specimen being collected. Your book says 3 minutes, but the correct answer is 2 minutes. You never want to draw on the side of a patient who has had a mastectomy, so breast tissue removed, because it can cause lymphedema. So if you have someone who has a double mastectomy, the choice of draw is going to be the dorsal hand vein and placing the tourniquet on the forearm and not on the upper arm. I'm not sure what I mean by can you draw from patient's feel. I must have mistyped something there. I don't know what I was saying there. A couple other things to think about. If there's a large hematoma, we don't draw through it. We go somewhere else. If there's a AV graft or a fistula from like somebody who has dialysis, you don't place a tourniquet on that arm. If the brachial artery is right below the basilic vein, you're not going to draw that. Basilic vein, you're going to look somewhere else. Tattoos, technically we don't draw through tattoos. Now, obviously sleeve tattoos are becoming more common and you may not have a choice, but if you can find an area on the arm below the bicep that isn't tattooed, try and draw that area. Edema, like someone who's really edematous, like really swollen, we typically don't draw that because the tissue fluid will actually interfere with the test results. And I've actually drawn where I just get tissue fluid because you can't find the vein in all that fluid in the interstitial space. So you want to be aware of that. If they've had previous blood draws, like you guys have seen each other in class, you can draw there. It's just only if they have a big hematoma, like some of you guys have right now, like Eric's arm right now from his pheresis, you're not going to want to draw in that site. So something to think about. So that's areas of draw and when you're selecting venipuncture sites. So a couple things to remember when you're doing that. Order of draw or specimen order of status, like the order status, like what is important. So like a stat is really important, which means it needs to be done right now. You can't just be like, oh, I have a stat and I'm not going to get it because I want to go to lunch. You got to stop whatever you're doing to do it. If you have a stat order and the doctor, you go to the ER and the doctor, or you go into the patient's room and the doctor's in there with the patient and you need a stat draw, you're gonna have to just tell the doctor, I'm here to get a stat draw. I'm gonna have to draw their blood. So that's okay. An ASAP is within 30 minutes. A stat is usually 15 minutes. So I'm gonna put on here within 15 minutes of the order. 30 minutes, within 30 minutes you want to collect it, but you have a little bit more time to run that sample. Routine is just within your 8-hour shift. It doesn't really matter. A time study or a time draw is you have to draw it at a very specific time. And that must be drawn within 5 minutes before or after the requested time study. So if the time study says 1400, at 1400, 2 o'clock in the afternoon, you have between 13:55 and 14:05 to get that sample. So because it's critical, and there's I listed some examples here, like cortisol levels, glucose tolerance test, therapeutic drug monitoring, the peaks and troughs of like antibiotics, things like that. They have to be drawn in a very specific time frame to get an accurate value. Otherwise, you're going to get a bad value. So that's some things to keep in mind. There was quite a few questions on how to approach patients, so I kind of wrote down some stuff that, I don't know, we talk about, but I don't know if we really made pointed. So one thing, you want to make sure you get verbal or implied consent. If the patient refuses to get their blood drawn, you cannot proceed. You have to stop. If the patient is like, well, whatever, I don't really want it, you need to get them to say it is okay for you to draw their blood. If they're being, you know how you get those older patients and they're being difficult and they're like, well, I really don't want to do it, but I have to. I guess I have to. Well, if they say something like that, you need to say, is it okay if I draw your blood? I need a yes or no answer. You got to be pretty direct with them so they don't, say no. Because then if you say, well, I didn't tell them they could do it. I said I didn't want them to do it, but they still did it. And they can accuse you of assault. So you really got to be smart about that. Make sure the patient is aware of what you're doing. Explain the procedure if they don't know. Ask the important questions. Have you had any complications with this? Have you ever had this procedure done before? Things like that. It's really important. Be able to explain expectations without increasing the patient's anxiety. So don't do like, oh, it's really gonna hurt, or if you know the patient's anxious, you got to be aware of that and try and hurry the process along. Don't like, you got to show confidence. And then when you check the needle, don't like hold it up and look at it in front of their face. Something, because they see that long needle and they're thinking, oh, you're gonna stick that whole thing in my arm, which you're not, but they don't know that. So keep those things in mind. Listen to your patient, what they say. If they say, don't draw me on this arm, don't draw them on that arm. If they say their veins roll, say, okay, I hear you. Validate that you hear them. When is it necessary to have a patient's ID confirmed by another healthcare provider? That's probably the most important thing we do, is identify our patient and making sure. The biggest mistake you can make is drawing the wrong sample or mislabeling the sample. So when is it necessary to identify your patient? Every time you draw their blood. How do I identify your patient? We ask them to verify their name and date of birth by telling us, not by saying it to them. If you're in-house, you want to check their ID band, but you still want them to tell you, my name is Michelle Kelly, my date of birth is 2/16 of, whatever year it is. So if the patient is unconscious, like they're not, lucid or aware of what's going on, you may have to confirm their ID with a nurse. If you've never drawn them before, it's a good idea to confirm their ID with a nurse. Other things you want to think about is you might want to get assistance, because sometimes when you stick somebody who's unconscious, they'll like pull away because they don't know, they feel pain, but they don't, they're not cognitive. So you may want to get assistance when drawing. The one thing I will say with unconscious patients is you still want to communicate with them like they're awake. And the reason I say that is because I've actually had unconscious patients that can hear you, and when I don't, and then I stick them, they jerk. But if I tell them there's going to be a poke here, and I talk to them just like they're awake, almost like I'm talking to the plastic arm, they don't. So sometimes I think they can hear us, but we don't know it. So just treat them like a regular patient. Other things to think about is mental disabilities, mental illness, mental health issues, like if they're not like schizophrenic or something like that. Dementia is a big thing that you may want to get. If you don't have an armband or something to identify them, you may want to get somebody to assist with identifying them. Children, obviously the parents are going to identify them. Anyone under like the age of 3, or even, 4 even. This is a big one that we see here in Dallas area because we have so much diversity, but people that don't speak the language, speak English. If they don't understand English, this is what they do. If you ask them a question and you don't know that they don't speak English, and you say, is it okay if I draw your blood? They're like, and do you have any questions? And they're just nodding their head up and down. That's a clue that they're not understanding. If they're not answering your questions, don't just ask them yes or no questions, because then you're going to get that head nod and everything's going to be a yes. So how do you get a translator? Don't use their children. Don't use a family member. If you have someone on staff that speaks that language, that's the best. The other thing, most facilities have translating systems where you call in to find someone who speaks that language and you communicate on a 3-way call. So they're listening, or you put them on speakerphone and you can ask them to communicate with you. So you have a translator in the room with you on like speakerphone. That's the best. Because you don't want to give false or incorrect information to someone who thinks they're just acting like they know the language. Okay, so some things to think about when you approach the patient. Communicating, how should we speak with a patient? Think about what you do with a patient when they're anxious, different scenarios, somebody who's hard of hearing, things like that. Is it okay as a phlebotomist to share information regarding the tests the physician has ordered? Now, we talked about this in class, and there's a gray area here. So if the patient asks, what tests are you drawing? You can tell them your doctor ordered a CBC and a CMP. Now, if they ask you, well, what is that? That's when you want to say you need to speak with your provider. Or if they ask, is this to see if I have heart disease? You need to speak with your provider. So if they're asking more of what I would say here is like an interpretation, or explain results, or explain testing, or explain how it relates to disease, then you want to have them speak to a provider. But if they're simply asking, what tests are we drawing? You can tell them a CBC and a chemistry panel. But other than that, no other information. If they're like, well, what will that tell them? Say, you need to speak with your provider. Okay? We talked about that in class a little bit. Things to think about when you're talking with your patient. I just put down things to remember when performing the venipuncture procedure. Tourniquet placement, know where it's at. Time, how long is it on? How long should it be on? How tight? If it's too tight, what can happen to your sample? Most commonly, when we tie a tourniquet too tight, it can cause hemoconcentration, which can falsely elevate analytes, particularly electrolytes like sodiums and potassiums. So think about that. And then if your tourniquet's not on tight enough, you're not going to get a good feel for a vein, so it can affect your vein selection. Vein selection, palpate with your index finger, not your thumb or not your middle finger, because you have the most sensation. Don't have the patient pump their hand. Can you guys see? Where's my picture? Pump their hand. You just want them to hold a nice tight fist. Sometimes if you have them lower their arm below their heart, you can fill that area of the body with blood. If they're really cold, you can put like a warm compress on them, like particularly if you're drawing maybe a hand, like a dorsal hand vein, you can do that. To increase their blood flow, ask them to drink water, because if they're dehydrated, it's going to be harder to feel for a vein. And then make sure the vein isn't too close to an artery. That's the other thing, which we've already talked about. You got to be aware of where the artery is, because you don't want to go too deep. So that brings me in, how do you know you're in the vein? A lot of times when you poke, I don't know if you notice this, I see it when you guys stick. You guys may not feel it yet, but there's a give. There's like a little give in, and I see it when you stick. Like I can see your needle slide and slide quickly because it hits that vein and it's in liquid compared to tissue. So there should be a little give when you hit the vein. And then when you pop the tube on, you know if you are in the vein or not. The thing is a lot of times when I tell you guys, just pull back, it's because I saw the give, and if there's no blood, I'm like, oh, they went through it. So start paying attention to that give in the vein a little bit. How long should a phlebotomist wait for alcohol to dry? 30 seconds maybe. The reason why, one, it kind of activates and it disinfects and it kind of activates with the bacteria and gets rid of it. You want it to not sting the patient when you stick the vein. Couple things. Angle is 30 degrees or less. Like I said, 15 to 30 degrees is a good choice. Mixing your tubes, a good number is 8 to 10. Of course, manufacturers will give you very specific things. I think the blue top is like 3 to 4, according to the manufacturer, but it's not going to hurt it to mix it longer. The reason we mix it is we want the anticoagulant to mix well with the blood because we want to prevent microclots. We don't want to get any of those little clots because it'll affect platelet results, it'll affect clotting factors. We want to make sure we're using plasma, so you want to mix it well. When you remove your needle, make sure you activate your safety device immediately and you use the safety device to cover up the needle. We don't bend it, we don't break it off, we don't cut it off, we don't recap it. We use the safety device and then the whole thing goes in the sharps container. We don't take the needle off, we throw the whole thing away intact. So make sure you always label your tubes in front of your patient after the specimen is collected, never before. Don't pre-label your tubes or your sample. Never do that. And you always want to do it in front of the patient, and then you want to confirm the information on the tube. And then you also want to make sure you date, time, and initial on the label. It's good to give the patient post-venipuncture instructions, like when they're done. This is something we really haven't done. But you don't want them to carry like a heavy bag on that arm. So you may want to say, if you're carrying a heavy purse or something, don't carry anything heavy with that arm. Take the bandage off in 15 minutes. Just don't carry anything heavy for 1 to 2 hours is a big thing. So that they don't start bleeding again. Because I've actually had people come in, like they left and they put their purse on their arm and they get out the door and they turn around and come back and they're like, oh no, and their blood's running down their arm. So sometimes if you use cotton balls too, it can, like when they take it off, it'll pull the plug away. So you always want to use gauze. We don't use cotton balls anymore because it can actually pull the clot off and then they open up the wound again and they start bleeding. So you don't want to do that either. I put this slide on here. I think I need to make it bigger so you guys can see the whole thing. But honestly, you guys can see, I put all this on here and you guys can see the whole thing. I added this, what does it bind with in the coagulation process. I can't remember what SPS does, so you guys got to look that one up. Some of these are NA because they're serum tubes, so there's no binding. And this one's EDTA, so it's the same as above, so binds with calcium. There is a chart in your phlebotomy textbook. I think it's on chapter 5, table 5.1, on like page 140 or something like that, that has a chart in there about the coagulation effects, like how does it clot. The biggest one that's different is your heparin tubes. Your heparin tubes do not bind with calcium, so that's the one you kind of want to remember because it's different than all the rest of them. That might help you. And I don't remember what SPS does, so look that one up. But I put that chart on here. We wrote it down in class. We've gone over this, but you need to know pretty much this very well because there's multiple questions that this chart, if you know it, will answer. I put this on here because I wanted to talk about the different samples. This here is called hemolysis. What is hemolysis? Hemolysis is red cells that get destroyed in the process of venipuncture. Why do we see hemolysis? A couple different things. What can affect it? 1, we leave our tourniquet on too long. 2, we don't let our alcohol dry. It can cause hemolysis. 3, we have a difficult draw or a small vein that is not, the blood's not flowing well into the tube and it can chew up the red cells. 3, we use too small of a needle, can cause hemolysis. Those are all the reasons we see hemolysis. These here, these last 3 are hemolysis. It's basically a reddening of the serum. This is a normal serum tube. That's what normal looks like. So What is the biggest analyte affected by hemolysis? Potassium. Potassium's affected the most by hemolysis. There can be other things affected, but potassium's the most common one. We'll see. We will reject hemolysis every single time. If we see hemolysis, it's 100% rejected. I will not run a chemistry or anything on a hemolyzed sample. Even a CBC, I'll reject it. This is called lipemia. This is normal, and this is lipemia. It's a little bit like it's milky or cloudy, and this is fat found in the blood that's staying in the system. Now, we can run samples on lipid samples that are lipemic. We don't necessarily reject them, but we do. It can interfere with some tests, so we might have to report some invalid tests because there might be a few that we can't run. And then this is jaundice. This is normal, and this is abnormal. This is what we call icteric. So it's basically liver issues, and it's usually, the reason it does that dark greenish yellow color is it's bilirubin found, really high bilirubin found in there, usually due to liver disease. So that's jaundice. We do not reject icteric samples either. We will run them. Usually their liver enzymes are extremely high, and they have some type of liver or kidney function issue going on. So these are affected. These are because of the patient's disease state. This is due to the fact that the phlebotomist created an error. So hemolysis is because of phlebotomist. Lipemia and jaundice or icteric is caused by a disease state in the patient, not anything the phlebotomist did. Okay. Some rules in phlebotomy: only 2 attempts before asking for assistance. You never draw anyone. If you miss twice, you're done. No more. Absolutely no more. Even if you're like, oh, but I know I can get that. No, you cannot. You got to get someone else. Selecting equipment requires the size of the vein and also the size and condition of the vein. Like if it's real fragile, like an elderly patient, like if it's a real fragile vein, I'm probably going to use a smaller butterfly. I'm not going to use a great big vacuum tube because it's going to suck out too fast. I'm probably going to use a syringe instead of a vacuum tube. So that's something to think about. If you accidentally hit an artery, which gosh, I hope you don't, but when you do, it like pulses into the tube. Like you can see this, and it's bright red instead of like dark red. And then, so if you do that, you want to make sure you hold pressure for 5 minutes, and you need to report it to a supervisor. Don't just ignore it. If you get a needle stick, you want to make sure that you, if you stick yourself with a needle, go to a sink, squeeze it, wash your hands really good, thoroughly, and then notify your supervisor. Never draw a patient who refuses. Always follow the order of draw. For example, like if you draw like a green top and then you realize you need a blue top and you're like, oh my gosh, I have heparin, I drew heparin. One thing you can do is draw like a couple waste tubes, or even draw a couple waste tubes and then draw the tube that you want to test. But make sure you throw the tubes away that are waste tubes, because you can clear it. So you could draw like 2 or 3 sodium citrate tubes and then throw those away and then draw 1 for testing. So you can reset it. You don't have to stop and like, oh, I got to restick them. You can actually fix it when you're in the process. So something to remember. I don't think I've ever talked about that. And then the last thing I want to talk about is arterial blood collections. There are like 5 or 6 questions on this, and I didn't really cover it. So I think I talked about the Allen test, but that was it. So please read about arterial blood draws, like what is occlusion, how to perform the Allen test, where do we draw arterial bloods. And typically it's done by respiratory. We usually draw it by the radial artery. Why do we use the radial artery? What is the Allen test? How can you tell if there's an occlusion? What do you do if you draw it? So like I said here, basically, please review the arterial blood draw requirements in your textbook because you will be tested on this procedure. I did not realize they covered it in this test, and so I want you to make sure you actually read about it. Okay, and that's all I have. I want to wish you guys the best of luck. I hope you have a great week next week, and we'll see you the following.